Premium lens surgery entails premium expenses and expectations. The substantial extra expense incurred by the patient for the services associated with the deluxe lens implant considerably raises the standard with respect to the final result of surgery. Needless to say, a thorough macular evaluation is of paramount importance. In this video, we will present a case of a patient that underwent uneventful phaco emulsification with implantation of a premium multifocal IOL that was later diagnosed with a subtle unilateral epiretinal membrane, or ERM, which was successfully managed by vitreoretinal surgery. The patient is a 63-year-old white female with no other significant medical conditions but controlled systemic hypertension, who presented with a complaint of decreased visual acuity on both eyes. It is worth mentioning she never complained of metamorphosia or any perceived entoptic pattern. The preoperative examination showed grade 3 nuclear sclerosis and grade 4 cortical cataract on both eyes, although the latter was more significant in the left eye. Best corrected visual acuity was 20/30 on the right eye and 20/40 on the left. The remainder of the examination was deemed within normal limit, except for 2+ guttae in both corneas. The only test for macular health performed preoperatively was the Lambda 100 grading pattern test that showed potential visual acuity of 20/25 on both eyes. She especially requested premium multifocal IOLs and underwent an eventful phaco emulsification with an implantation of a Restore lens with a +3 add. Visual acuity was 20/30 and Jagger 2 unaided 1 week postoperatively, although she complained of blurred vision. A dilated retinogram was performed initially to rule out CME, but to our surprise there was a subtle blistering epiretinal membrane inferior to the macula. The patient decided to await further retinal evaluation. On the 40th post-operative day, best corrected visual acuity was 20/30 in Jagger 1, although she was still bothered by some metamorphosia and blurred vision, especially for reading. She already had pursued a second opinion elsewhere, and a significant posterior capsule opacification was noted, and a YAG laser capsulotomy indicated. The capsulotomy was performed with no visual improvement. A spectral domain 3D OCT was performed, displaying a very subtle epiretinal membrane, which is thicker and produces a stronger reflection than the posterior hyaloid, as seen here. The retinal scan showed a preserved fovea. The right eye examination was unremarkable. The patient displayed her disappointment and was oriented to seek a retinal specialist's opinion. After consultations with several colleagues, with opinions differing from IOL exchange to ERM peeling, she eventually decided for the latter, which was performed elsewhere 5 months after the primary procedure. On her last visit, she was 1 month out from the ERM peeling and reported visual improvement. Uncorrected visual acuity was 20/30, best corrected visual acuity was 20/25, and she could read Jagger 1 unaided. A control OCT showed complete removal of the epiretinal membrane, as seen here. Once you have done enough cases, sooner or later you will find out that you missed an ERM or an abnormal macula caused by other pathology. A preoperative OCT has been advocated by many refractive surgeons, although not considered a standard. Some colleagues, especially in the developing world, claim the patient is already paying for extra charges, and adding one more to the bill like an OCT can jeopardize the doctor-patient relationship. There are several ways to access the macula, like laser interferometry for example. They all are least reliable when dense cataract coexist with macular pathology, the very situation when they are most needed. Idiopathic epiretinal membrane occurs as a result of the retinal glial proliferation along the vitreomacular interface, inducing a tangential tractional force on the retina, leading to deformation of the retinal architecture. Generally, ERM is asymptomatic. Therefore, most patients with the disease, like our case, have normal or nearly normal vision with occasional metamorphopsia. The onset of the symptom can be slow and perceptible, such an Amsler chart is the only means of detection. Detection of metamorphopsia using the Amsler chart is subjective and can also be influenced by media opacity. Recently, with the introduction of spectral domain OCT devices, it has become possible to image the macula with better resolution and at a much faster scan rate. ERM is commonly included in the exclusion criteria for multifocal implantation. Its diagnosis can be difficult, like in our case, with subjective testing. For this reason, we strongly believe the use of routine pre- and even post-operative OCT examination will become increasingly popular among non-retina specialists. Many publications have emphasized that multifocal IOL implantation can make vitreoretinal examination and surgery more challenging, especially for the vitreomacular interface, because the retina specialists claim they lose visibility and contrast sensitivity when viewing through those lenses. We can hypothesize the inferior ERM in our case only became symptomatic after the implantation of a multifocal IOL because of the interaction of the macular elevation caused by the membrane with the IOL optics. Although our case was successfully managed by vitreoretinal surgery, we should bear in mind that when dealing with a high expectation population like the one receiving presbyopia correcting IOL, we should resort to the technology that will guarantee no pre-existing retinal pathology is undiagnosed. Thank you very much for your kind attention.